This podcast is CME eligible. To learn more about CME, Alex, what do they do?
They can either go to the CME tab associated with this episode, or they can go to geripal.org/CME.
And on to the show. Welcome to the Geripal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, we have a full house for a podcast on rural palliative care.
We have a full house for rural palliative care. Jeanie Youngwerth is our first guest. She is a palliative care doctor at the University of Colorado. Jeanie, welcome to the Geripal podcast.
Excited to be here. Thank you.
We're delighted to welcome Adie Goldberg, who's a palliative care social worker and clinical coordinator of the Washington State Rural Palliative Care Initiative. Adie, welcome to the Geripal podcast.
Glad to be here.
And delighted to welcome Karl B. Bezak, who's a palliative care doctor at the University of Pittsburgh and UPMC. Karl, welcome to Geripal.
Thanks for the invite. Glad to be here.
And last but certainly not least, a dear friend from many meetings, go back a long way, Gregg Vandekieft, who's a palliative care doc, works at Providence St. Peter Hospital in Olympia, Washington, is medical director of the Washington State Rural Palliative Care Initiative. Gregg, welcome to the Geripal podcast.
It's great to be here, and I'm going to share, Alex and Eric. I heard Sterling Hardjoe being interviewed by Terry Gross, and he said, "You know, Terry, I always knew that I would have made it if I got to be interviewed by you." That's kind of how it feels being interviewed by the two of you. It feels like we made it.
Yeah. You don't need Terry Gross anymore. You're
right.
Yeah. Okay, we got a lot to talk about rural palliative care, but before we do, we always start off with song request. Gregg, do you have the song request for Alex?
Yeah, Three Dog Night, Out in the Country.
Why did you choose this song?
Well, when I was thinking about the bleak health economics landscape in rural communities, I first thought of John Mellencamp's Rain on the Scarecrow, but that's too depressing. I wanted something more uplifting, and Three Dog Night was a big band in my childhood, so I thought Out in the Country by Three Dog Night.
Wonderful.
Whenever I need to leave it all behind, or feel the need to get away, I find a quiet place far from the human race, out in the country, before the breathing air is gone, before the sun is just a bright spot in the nighttime, out where the rivers like to run. I stand alone and take back something worth remembering.
Wonderful song. Good choice, Gregg.
Excellent.
All right, we got a lot to cover. I want to just start off personally, just briefly from each of you, kind of what motivated you to do work in rural communities, especially rural palliative care. Adie, I'm going to start off with you.
Yeah.
What got you to do this type of work?
Well, I had the opportunity to work in a tertiary hospital in southwestern Oregon, and I watched patients come in from Northern California and Eastern Oregon, and I watched these beautiful discharge plans get derailed within 48 hours of patients going home.
Yeah.
And so I did my PhD dissertation on the seamless delivery of palliative care in rural Oregon. Forget which state I'm in. So, anyhow, it just, my heart's there. I went to college real close to where Gregg grew up in a small town in Iowa, and my heart's in rural communities.
Yeah. Do you live in a rural community?
I live in Spokane, Washington, which people in Seattle would say is rural. But,
It's all relative, right?
yeah, but I have a cabin. So.
Oh, you have a cabin.
Yeah.
How about you, Jeanie?
I would say mine was by opportunity. It came across one day that some folks from rural Colorado reached out and wanted to collaborate. I love to do innovation. I think I'm like most Coloradans where we love the mountains, we respect the mountains, and anything that we can do to help our colleagues in that area and patients to access palliative care. So this just sounded exciting and fun and meaningful.
Oh, that's wonderful. Karl?
Yeah, well, he found me, to be honest. I was a fellow at Mount Sinai back in 2018-19, And I met Bob Arnold, who I suspect many of you know. And he had a fantastic project using AI to identify patients in rural areas in Western Pennsylvania. And it drew me after a fellowship. And I've never looked back. It's been a fantastic thing working in rural communities with telepalliative care. And it really aligns with who I am, my passion for equity and access to our specialty.
Yeah. 2018 AI. That's like pre-chat GPT.
Oh, yeah. Early adopters for sure.
Okay, Gregg, how'd you get interested in this?
As Adie mentioned, I grew up in farm country in a small town in Iowa. And then my first practice out of residency was in a small town in Northwest Washington, and saw a lot of people in the rural community there. And then when I came to Olympia, we serve a very rural area. Many of our patients come from the Olympic Peninsula, Southwest Washington. This particular work, though, similar to what Jeanie and Karl said, it found me. I got called by the director of the Washington Department of Health's Office of Rural Health. She said, "Gregg, I'm thinking about starting a rural palliative care initiative. What do you think?" I said, "It's a great idea." And she said, "Good, because you're going to be my medical director." And that was in 2015. And so I've been doing this work now for 10 years.
Wow. And then when we think about like rural palliative care, what does that look like? Like, is that just the same thing we do in urban palliative care?
Adie, I'd love to hear your take.
Well, no, it doesn't look anything like urban palliative care.
Why not?
And everybody jump in with me about this and what you've seen. But basically, Gregg and I joke, we call it the MacGyvers of healthcare, that people cobble together whatever is needed to be done in a community to make it happen. And people often in urban settings would never consider doing the things that a nurse does or a CNA does in a rural area. People don't stay in their lanes in rural communities, and they can't, because the services that we take for granted in the urban setting are not available in rural communities.
Yeah.
I think one of the really unique attributes is, you've heard the expression, if you've seen one palliative care program, you've seen one palliative care program. But the champions in the rural communities are so widely variable. It's commonly a nurse. Sometimes it's a small town family doctor. Sometimes it's a hospital pharmacist. Sometimes it's a community health worker. And the champions are so crucial because they're the ones who know what exists in the community. And if they're going to MacGyver, they know how they can MacGyver things to make it work.
Mm-hmm.
Yeah. We may have to explain MacGyver to the younger listeners.
Oh, boy.
Dean Anderson. Anyone? Great hair. I'll jump in just to say that it's so variable. And the thing that really unites rural sites is their resilience, their resourcefulness, the MacGyverness of it all, to sort of figure out how to make high quality, especially palliative care, work for their community. They know everybody in the community. And so when we think about providing that care, it's so personal, which kind of is wild because when we're doing it a lot by telehealth, which doesn't seem so personal, but it's really the connections with champions where they are that makes it work.
Hey, and Karl, can I ask you?
Jeanie, love to hear your thoughts.
Yeah, go ahead, Jeanie. Before I ask Karl a follow-up question.
I was going to say, to add to what Karl is saying, I think he's right that it's so variable. And what we can really do is leverage the strengths of that particular community, what's important for them and that organization, and then align with it so that we can lift them to something where we can build something, we can help folks to build something that becomes sustainable in that community and is high quality specialty level palliative care.
Mm-hmm.
Jeanie, that brings up a tension though in palliative care currently, is this idea of like we need some standardization of what palliative care is. So when we say somebody's getting palliative care, like we have some sense of exactly what that means, versus this tension about making care very individual for a particular person or particular community and delivering the right thing to the right person, the right time, and the right amount. Do you think there's that tension here?
It exists everywhere. Absolutely. And I think that's where, if you hear each program that everybody's involved in, it looks very different. And it's tailoring to that need for that particular community. So a lot of things are going to be more generalized palliative care, and some things are going to be more at that specialty level.
Can I ask you a question? Can I go philosophical here for a moment? If you could bear with me. I don't want to derail. I know Eric has a long list of questions.
Go,
okay,
go,
so
derail.
All right, so I was fortunate to train at the Brigham in Boston, where Paul Farmer was a physician, and many of you, our listeners, have probably heard of Paul Farmer. Started this worldwide movement to improve access to life-saving medications that really changed the landscape of and a public health approach to how we treat diseases like HIV, tuberculosis worldwide. And I remember hearing him talk about like how he would go take, antivirals from the pharmacy at the Brigham, sneak them in his suitcase, and then go off to like Haiti or other places, because he believed firmly that the standard of care at, the best hospitals in Boston should be the standard of care everywhere around the world, and everybody should have access to the treatment. So you can see where I'm probably heading with this, right? On the other hand, like the answer to like what should rural palliative care be cannot be the exact same thing as it is in the hospital. And like I feel this tension in my mind, and some of what, the choice that people, sometimes it's a choice to live in rural areas, and sometimes they simply can't afford to live in urban areas and they'd like to. But part of that is that there just it's not realistic to try to impose our urban models of palliative care and the high standards that we hold many of these models to, in terms of like all the components of the interdisciplinary team, et cetera, on these rural environments. Can anybody help me out of this conundrum?
Well, Gregg and I often talk about our takeaway is humility when we approach these communities. The last thing they want is our urban wisdom. And we have a colleague who always says that the folks in a rural community have a PhD in their community. And so part of our learning is from their PhD. And how do we meld what you're saying about standards and wanting the domains covered, and how do we do it? But it may be covered by someone that we don't anticipate. Gregg talked about a champion. One of the champions in a rural community was the chaplain, and moved to tremendously integrated team. So it's not that we're lowering the standards, but maybe we're changing who we think delivers it in a rural community.
I'll piggyback on that to comment that one of the things we do whenever a new community joins the Rural Palliative Care Initiative, and we're up to about 20 communities now, not all of them are as active because their champion moved on, but we first do an asset and gap analysis. We look to see what does the community have that can help fill in the space. And then we do a lot of virtual support. So many of the folks that live and work in the community will not have any sort of specialty certification in palliative care, but they have access to a full specialty interdisciplinary team in multiple ways, through online case consultations that we do regularly, through open office hours that we do regularly, and through individualized consultation for the community. And so some of the, if I think about the National Consensus Project delivery, what is the model supposed to look like and what are the standards? Some of that will be done on site locally. Some of it's going to be virtual.
And we'll have a link to the NCP standards as we talk about them. So it won't be a podcast on, but it sounds like, you can potentially, like, why not both? Why not have these experts in their community, but also have access to highly trained, specialized palliative care? Is that what I'm hearing?
Yeah.
Mm-hmm.
I think so.
Karl, you want to say something?
Absolutely. Oral palliative care is the epitome of personalized medicine. And when I say that, I mean exactly what you're talking about, Alex and Eric, is like this melding of that local knowledge with resources of the big city. I think something that is debatable in terms of approach is taking a big city expectation and putting it in a rural community.
Mm-hmm.
I think that's not the way to go. I think it needs to come, as one of our colleagues says, from the bedside up, not from the spreadsheet down.
Yeah.
We need to be in the communities that we want to build and serve first. They need a big seat at the table, or else it's going to fail.
And I would add to that, I strongly believe that has to have local integration. So we're not bringing a program and saying this is what needs to happen, and this is, it's now reliant on the program that we are bringing to them, but it's something that we have integrated. We are part of their program, and if anything, we're enhancing it, but it's not something that's going to be reliant on us. So that local integration, I think, is key for many reasons. it helps to cover the buy-in part, the sustainability part, all those things. And people in rural areas especially, they want to be treated by their own.
Mm-hmm. Absolutely.
I got a question. Karl mentioned earlier on that he got into this because he was also really interested in equity. Is rural palliative care and rural health an equity issue?
Absolutely.
You're talking to a social worker here. So, yeah, absolutely.
Why?
Why is it an equity issue?
Yeah.
Because, I don't believe healthcare should be based on your zip code. And rural zip codes are underserved in so many ways, both in terms of having access to palliative care, having timely referrals. Now we're seeing dramatic cutbacks, disproportionate number of Medicare, Medicaid patients, aging population, educational disparity. I mean, I could just babble on and on and on. But, to have lower income and have your closest palliative specialist be an hour's drive away with the cost of gas, that's an equity issue.
Yeah, Adie has a series of slides she uses where she talks about health disparity, but it's disparity in rural communities. And that goes beyond palliative care. Yeah. Access to resources in general. When you look at mortality rates, morbidity rates, things of that nature in the rural health setting, it's significantly worse than it is in urban settings.
Higher suicide rates, higher mortality rates, higher disability rates, lower socioeconomic status. The list goes on, which is really interesting because 1 in 5 Americans live in more rural.
Mm-hmm.
Correct. Mm-hmm.
Yeah,
absolutely right.
And we usually don't think about that when we hear the word equity.
Right. Or inequity.
Yeah.
Mm-hmm.
The needs, especially palliative care, appropriate patients, those with serious illness, are similar to patients in urban areas, but they're also different.
How so?
Well, I want to hear from Jeanie and Adie. Gregg, what you guys think. I will say that it's meeting that patient where they are. They need someone that understands who they are in a way, because I think being not from a rural area, I'm from the suburbs of Philadelphia myself. It's taken me a long time to sort of understand how to sort of communicate serious illness communication with patients in a rural area. I have a different background than I do, right? So I'll just start off by saying the needs of patients in a rural area, they need someone that speaks their language in a sense and understands where they're coming from, rather than coming down from the ivory tower.
Okay, I got a question on that. So this is kind of reminds me of like age-friendly healthcare, or the work that we do in geriatrics to minimize the harms of hospitalization. At one point, older adults, we need to do this stuff. But man, not waking somebody else at midnight up for a lab test if they don't need it should be applied to everybody. How much of this is really a rural versus urban thing versus saying, no, this is the type of individualized care. It doesn't matter where you live. Everything you just said seems like we should be doing that for everybody, because we're going into other people. It could be about somebody's culture, background, all of these, even microenvironments in an urban setting matters too. How much of this is just we should just be doing it flat out for everybody versus just, it matters more so in rural settings?
Well, it should be flat out, but I worry that the finances aren't there for rural communities.
Yeah.
And so when we talk about how we address those equity issues, I feel like the rural communities that we serve are the Cinderellas and tend to get the leftovers. And we have one nurse. When Karl, to answer your question, when I was thinking about someone who understands them, we worked with a nurse who, on a hybrid model, Gregg, and remember, she would say, "Oh, I dated his son for prom. Oh, I barrel raced with her in high school." And, we can't offer that in the city.
I would say that, Eric, it's more of a yes and rather than an either or. Yes, everybody ought to be given that same quality of care, but the element that's unique in rural settings is often a combination of geography and culture. Some of the cohorts we work with have a very strong tribal presence, and you need to work with the tribal elders or somebody that has an expertise in that culture, that community, if you're going to meet needs properly, or you're going to come with a model that doesn't fit the community you're trying to serve. And so recognizing those things, Adie and I also learned when we were doing direct telehealth to some critical access hospital how important the connection with the land is for many rural residents. They want to be on their ranch. They don't want to be transported to another hospital in a larger community. And we found that we saved a lot of resources by not transferring people when they didn't need to be. But more importantly, they didn't want to be transferred. They wanted to be cared for in their home community by people they know.
Yeah.
And so if we were able to support them in a way that was possible, it made a meaningful difference in their quality of care and the quality of life.
Which I can imagine that you guys, when you're putting together these, initiatives, how to create palliative care in these communities, there is a lot of challenges. I can imagine one of them too, like I want to get care of my community. And like one challenge is rural hospitals are closing left and right.
Yeah, it's terrible.
Maybe we
right?
just go around like I'd love to hear from each of you. Like, what are the biggest challenges that you are seeing and you're facing right now delivering rural palliative care
today?
Jeanie, I'm going to start with you. Thoughts?
I think it's probably outside of the hospital setting and reaching those folks in their home setting. And I don't know that it's any different from today than when we started the program years back. With, a lot of the barriers are that it's distance, right? People just live so far away that number one, trying to drive to people becomes impractical. Number two, trying to do tele can become impractical because people don't have, access to internet or cell phones or whatever that may be. So those things I think still exist.
So big digital divide there.
There's a huge digital divide that was before and still is there.
Yeah.
One of our communities recently started a project where they use satellite phones because it's in a mountainous area where they often don't have internet. They don't even have good cell service. And so people will go out with a satellite phone and then they can set up Zoom meetings with specialists, primary care from their home doing that.
Wow.
But the windshield time that Jeanie referenced is a big deal in the rural settings. One of our communities was a hospice desert. Even though there was a hospice that had a certificate of need to serve them, they were over an hour's drive from the office and they just didn't have the staffing. So their community had no access to hospice until a couple of weeks ago when they got something set up finally that was really a direct result of their work through the Rural Palliative Care Initiative.
Yeah, and sometimes we discharge patients to rural areas of California and they're cared for by all volunteer hospices.
Yeah.
Yes.
Yeah. So very different from the hospice that we may be familiar with or our listeners who practice in urban or suburban settings may be familiar with.
Well, and one real advantage the volunteer hospices have is they're not constrained by a lot of the Medicare regulations. So the 6-month prognosis, concurrent care, those are things that volunteer hospices can get around in ways that Medicare certified hospices cannot.
Yeah, that's great. Okay, so we've heard from Jeanie and Gregg. Adie, Karl, challenges?
Well, Jeanie, you said something really interesting, and it's true in our system too. Transitions of care are a real challenge. We have been able to set up our inpatient telepalliative service across 9 hospitals within our system, even between 2 states, Pennsylvania and New York. But I'll tell you, where we struggle is after we see the patient, give our recommendations, they're feeling good, the pain's controlled, everybody's happy, the primary team locally is happy. What do we do with the patient after that? Because it's really hard to get people into the clinic in urban areas for sure. But unfortunately, we've experienced people just lost to follow-up. It seems very hard for the digital divide reasons to reach the people after they leave the hospital. I think it's an infrastructure issue, to be honest with you, and lack of resources, which we've already touched on.
Even with telehealth, it's hard to...
It still is. It still is because despite all our efforts to set the appointment before they leave the hospital, build that trusting relationship, they understand what specialty palliative care is and is not, right? They're not able really to, for whatever reason, and we're looking into it, come to their outpatient appointment via telehealth.
Yeah.
It's multifactorial like so many things, but it's really a challenge.
Think about when you're driving your car and you're going through some kind of rural area and you're watching your phone and your bars go down and down and down. And there's one part where you're just not going to get any bars. You're not going to get through on your cell phone no matter what until some sporadic space where it comes up again, and that's temporary.
Yeah. Adie, how about... Oh, go ahead, Gregg.
I was just going to say, I was doing a hospice home visit a few years ago that I needed to call the home office, and I had to drive 3 miles before I could get reception.
Oh, boy. Yeah. Adie, I wonder if you have, what you have to add. And I also wonder if you could comment on that. You've talked about the strengths of the social fabric in urban environments, and that a lot of communities, people still know each other and you care for your neighbors. But there's also a flip side to that, isn't there? That there are often many people who are living in rural areas who are very socially isolated, lonely, and a long way from friends and family.
And sometimes end of roaders where they move there intentionally so they're not bothered by people. And so oftentimes we'll see veterans who, we had one critical access hospital director who says, we don't need palliative care until we need it. And for these folks who have lived a life of running the show their own way to interface with the hospital in a given moment, suddenly be thrown into an environment where we're asking them to engage with us, and how do we navigate that ethically, I think is a very interesting conversation for rural communities. But Karl, what you said really raised a question for me, which is, I think, how do we help urban palliative providers write discharge plans that are accessible for rural patients when they go back to their communities? Because oftentimes they'll go, follow up with this, follow up with this, follow up with this. But it's either so hard to do or it's not even available. How do we help each other do that?
That's good.
Oh, you want me to answer that, Adie?
We want you to solve that problem, Karl.
Right now.
All right. So on the fly, let me give you the answer. I think that I don't have the answer, and I don't know that anyone does. What I will say is that it takes a village. We cannot put the responsibility on that inpatient hospitalist or that surgeon or that whoever is discharging the patient to figure it all out themselves, right? More and more in medicine, we're seeing team-based collaborative care. And I think that approach, I could say, is likely the answer. What that looks like right now, I couldn't say.
Yeah. I'll say that working with trainees in the hospital who are largely, right, our residencies still train mostly people in the hospital, right? That's the setting in which they don't do a lot of outpatient care, much less going into people's homes, much less like going out to rural areas into people's homes. And so one of the pushbacks I often get from the resident trainees who are working and training at the same time is, I can't imagine discharging this person to this rural area without all of these supports, which, they're used to having. And it feels like a ethical, moral dilemma for them. They feel like they are potentially doing harm to this patient, jeopardizing their safety by sending them home to die on their porch with their dog without the support of X, Y, and Z. Mm-hmm. And, a shoestring volunteer hospice. I wonder if you've encountered this and whether that resonates with you.
Isn't that an urban bias, though, that we think about, the poor folks who live in the rural communities? Because we had a nurse who went to a coffee stand to get her morning coffee, and they gave her 2 coffees. One was for her, and one was for the EMS call center director, who they knew before the nurse knew had been hospitalized with a recurrence of her cancer. And what she said to Gregg and myself was, when an illness happens in a rural community, it doesn't just happen to the patient, it happens to the entire community. And so, when your residents say, how do I send them back to this desert? To say, it's a different kind of experience for these rural folks.
Mm-hmm. It's great.
I think that's where we see people step up, right? When people say we care for our own, some of the most remarkable stories you can have is when you've communicated and collaborated with folks in rural areas about a discharge plan like you're talking about, and people will come up and take the bull by the reins and move forward. They are going to do things that they don't normally do, but they're going to do what's needed for that patient to make sure that they're receiving the best care.
And I'm going to come back to a comment that Adie made earlier about humility. We need to understand that there's a lot we don't know. Mm-hmm. And so setting up a discharge plan from an urban center to a rural community We need to ask questions. What are the strengths in your community? And how can we leverage those to help you get your needs met the best possible?
Mm-hmm. Yeah. And I can also imagine, just like in every community, there's variability. There are people who are shunned by their community or don't have that interaction to their community, or who are living farther away and I don't have those social connections that can make that happen. Is that what you see too?
Occasionally, a lot of the case consultations we get in our regular work with the Rural Palliative Care Initiative are community-based, and many of them are really chronic, complex disease management cases more than a classical palliative care case. And frequently, there are people that have mental health issues, housing issues, and it's like in any setting, it's like when I just don't know what to do, what am I going to do? I'm going to call palliative care. So we get a lot of those cases where the primary care has done a remarkable amount of work. They've done interprofessional work with social work, pharmacy, and others, but they're just at that point where it's like, now what are we going to do? And so let's see what the palliative care folks can offer.
So I'd love to hear from each of you too. We were talking about the challenges. Maybe it could be one of your own projects, another project you're seeing, like one project that or solution to delivering palliative care that you just love. Again, it could be your own, could be another one. So, Adie, I'm going to start off with you.
EMS involvement. We have communities in Washington that are using their EMTs as part of their palliative teams. It is amazing what they do. Post-discharge, they're trusted, first of all, because oftentimes they've been there multiple times to pick up someone who's fallen.
Yeah.
So this is a familiar face in the community. They go and they do a checkup post-discharge, and they participate in the huddles for palliative care in these communities. Sometimes they deliver Meals on Wheels. It is a beautiful marriage.
How is that paid for?
Good question. Well, in one community, the hospital owns their EMS service, and they see it in terms of reduced trips back to the ED and holding patients on. So, when they do the numbers, they can balance it that way.
Yeah.
Tell them the grabber story, Adie.
Okay, the grabber story. We had one EMS who kept getting called to pick up. It kept coming repeatedly. But what she wasn't down. It was her remote control that she couldn't figure out how to get to, and she just was calling the EMS to pick up her remote control for her. So the EMT went to the hardware store, bought a grabber for $25, and the call stopped.
I love it. And also, we'll just mention that we had Carmen and Katie Quatman, orthopedic surgeon. Her sister's a physical therapist at Ohio State, talk on our podcast about how they work with emergency medical services to integrate geriatric care into patients' home settings, including putting in grab bars, shower chairs, tacking down the carpet, that sort of thing. And the EMS providers absolutely loved it because they're like, I can't believe I just have to go back to their house again and again and again. I can't do anything. Now they can do something. So I love that this is happening in palliative care too. Okay.
Gregg, what's one thing that you've seen that you're all, wow?
We have a program in Southeast Washington that has really integrated a nurse practitioner with some palliative care background into their chronic disease management model. And it allows billing in different codes. It makes it a more financially sustainable model, but it also broadens the reach into the primary care space more effectively. And they've ended up seeing over a 3-year period a dramatic reduction in the ED visits and hospitalizations for people that are a part of their palliative care team now. And that reduction grew year by year. So as the team matured, they had a greater impact on prevention of ED visits and hospitalizations. But yeah, that chronic disease management integration, I've been really impressed with.
That's great. Jeanie?
I think that for the program that we helped to develop, one of the things that we knew from the start that we wanted to do was for it to be eventually a self-sustaining program, and we didn't know how when we first started it. And over time, it kind of became clear of how that happened, and it's something that I think is really impressive. And if folks aren't aware, they should be aware.
What's this program?
So the program that I'm talking about is at Valley View Hospital in the mountains of Colorado. But the program that I'm talking about that helped to make it sustainable is the University of Colorado Masters of Science in Palliative Care, which is an interprofessional program for folks to be able to have primarily online training to become community specialists. And there is now a related, now ACGME approved community fellowship program in hospice and palliative medicine for physicians, where it's an alternative pathway for physicians to become board certified, where they can train in their community home setting. So they don't have to leave. It's geared for folks that are mid-career, and so they would be mid-career fellows.
So they don't have to round with an inpatient palliative care specialty team at University of Colorado.
They don't have to move. They don't have to stop working where they're at. They continue to work at their local hospital or whatever that may be, their local setting, and have their training over years during that time, where they can then be eligible to sit for the boards in hospice and palliative medicine. So you can now get specialists in areas where you're normally, it's really hard to get a specialist, and it's hard to recruit specialists.
What's that program called for our listeners if they're interested in learning more about it?
So it's the University of Colorado Masters of Science in Palliative Care program and the related Community Hospice and Palliative Medicine Fellowship program.
And we'll have links to both of those.
I would imagine PCHETA, if it were passed, would help with this issue as well.
What's PCHETA? Is that an animal?
PCHETA? Can somebody help me out here?
Palliative Care and Hospice Education and Training Act. It's a bill that's been heavily supported by the American Academy of Hospice and Palliative Medicine. It actually passed out of a House committee in early 2020 and was going to be heard on the more broadly when the pandemic hit. It just hasn't gotten back the same level of traction since then.
Yeah.
And it works to provide research, education, and public awareness for palliative care.
Mm-hmm. And is anything in there about rural palliative care in PCHETA?
I don't recall anything specific to rural palliative care in PCHETA.
Okay. All right. Thanks.
All right, Karl. What's yours?
So mine is a program we had here between 2020 and 2022 called the Tele Goals of Care Pause. And it was the AI initiative I came here to build. Fantastic, providing telepalliative care to critically ill patients in rural emergency rooms prior to transfer. We were not blocking transfers, not rationing care. What we were doing was ensuring goal concordant care for critically ill patients before they got on the chopper. Before they got on the chopper and got so far away from their communities. We have data and found that, just like we were talking about today too, like people want to stay on the land. They want to stay where they are, and they don't necessarily want to be intubated, right? They don't want to go to the big quaternary center for all that care. They would rather, knowing what the best case, worst case, most likely scenarios are right there in the emergency room, being clear about that.
So is that AI case finding and then specialty telepalliative care into those rural hospitals?
Correct. Briefly, it was a model that was built here at UPMC to identify mortality risk after transfer, validated, published, and we used that algorithm to identify patients in these emergency rooms. We provided 24/7 telepalliative care at the point of service right there. And within less than 25 minutes conversation, we're able to have about a 2/3 reduction in transfer. But importantly, 94% goal concordant assurance.
It sounds amazing, Karl. Why are you saying this in past tense?
That's another episode. So it has to do with I think implementation and something that is often said in our field, that the impact of specialty palliative care is directly proportional to the resources allocated.
Yeah, and it sounds like the resources allocated to rural palliative care is minuscule.
COVID overshadowed it at the time. Yeah.
Did somebody say equity?
Yeah. Yeah.
Well, I was just going to quickly call out too, while we're talking about programs at work, because I want to acknowledge some of the work done by like Chris Piramelli in Alaska with Project Echo and some really good work. Alaska, which is not merely rural, but largely frontier. Marie Bakitis and the team at UAB who have done some really well validated work in rural palliative care. Michael Fratkin in Northern California with Resolution Care. Just wanted to call some names out.
There are huge leaders in this field.
Yeah.
Yep.
Can you briefly also describe, because we've talked about this initiative that you do, Adie. What is this initiative? in a nutshell?
The Washington State Rural Palliative Care Initiative. What is that?
Greg, you jump in at any point. This is a model for rural communities. We have 20 at this point. It is voluntary participation. And the foundational principle is Learning Action Network, LAN, where everybody teaches, everybody learns, we mentor each other. And so through a variety of ways that we can gather people together via Zoom, they mentor each other, they offer suggestions. Wow. There are 2 paid consultants, Gregg being one and I'm the other one, and it's offered through the State Office of Rural Health. Gregg?
Just yesterday, we had our regularly scheduled open office hours, and one of the folks in Forks, the Twilight community, was presenting a case of a guy that they couldn't find a discharge plan for. And somebody from an hour away in Port Angeles actually brought up a specific facility that had changed management. And she said, I think this would be absolutely perfect for him. And so we may have found a discharge plan based on that. We do monthly case consultations where we have physicians, social work, nurse, chaplain, and pharmacist, and people can present cases. It's a Project Echo-like model, but we don't have formal didactics, so we often jokingly call it Project Echo Light. And then we have individualized consultations. One team set up a consult with Adie and me when they were going to do a home ventilator discontinuation on a guy at then stage ALS. And we were able to walk the nurse and a nurse practitioner involved in that case through a lot of things that would have been new to them because they just didn't have that type of experience. And we do some didactics, but it's more individualized and personalized attention.
Can we do a lightning round?
Yeah. Oh, go ahead.
It's just one sentence. When you talk about workforce shortages, it's the isolation of the rural providers that also contributes to them wanting to go to an urban center. We had one nurse say to us that when I'm sitting at the kitchen table by myself charting at the end of the day, it's comforting to know there's someone across the state doing exactly the same thing and I can call her.
That's great. Yeah. I wonder if we could do lightning round, because we're running out of time, about policy changes you would love to see. Could be changes to like the Medicare hospice benefit, changes to telehealth,
you got a magic wand,
reimbursement, whatever you want. Anything's on the table. Could we go around your magic wand?
You can only use it once.
Policy change, Pachita, anything. All right. Karl, can we start with you?
Of course. I would love to get off this hamster wheel of, are we going to make telehealth reimbursement and parity a law or not? So I would love some confidence in having telehealth coverage and reimbursement parity be written into law, so we're not going through these checkpoints. Mm-hmm. I know a lot of folks have a lot of great ideas, but they're afraid that they're going to lose reimbursement at some point in the future, so they're not building it.
Yeah.
So we need steady reimbursement that we don't have to worry is going to go away.
Wonderful. Does it need to be parity? Like, there's less resources, right? You don't need your clinic space. You don't need your clinic staff.
Listen, equity, right? We should not necessarily downgrade or think that telehealth is any less effective.
Yeah.
For patients in rural areas, there's absolutely a need to bolster the dose of what's in telepalliative care with a full complement of IDT.
Wonderful. Adie, your magic wand.
I think right now what's just on the table are all this rural health transformation funding that is supposed to make up for the big, beautiful bill deficits in rural communities. And I want a palliative representative at every discussion on those conversations about how that money should be spent.
Wonderful. Jeanie?
I think in addition to what Karl's saying also, and Adie, that being able to have reimbursement for community palliative care, community at the home setting, having palliative care recognized as something that people can bill for and for different disciplines.
I'm going to throw in another thing, because I'm going to use part of your magic wand. I think more people should be thinking about how do we get rural people from rural backgrounds, rurally trained into palliative care fellowships. And that's why I really love what you're doing in Colorado, Jeanie. Gregg?
First off, let me just mention, please post the link to Stratus Health and some of the work they've done on rural community-based palliative care.
What is Stratus Health?
Stratus Health, and I think I sent that to Alex yesterday, but I can send it if you need it.
I think, yeah.
My magic wand would be to completely revamp the Medicare hospice benefit, get rid of the 6-month prognosis, make sure the entire interdisciplinary team is fully covered, and just provide high quality, seamless integration of palliative care from the time of serious illness diagnosis through death, and get rid of the hoops we have to jump through. The regulatory
You are really
burden
taking this
on
magic
hospice.
wand.
Magic wand is now empty.
It is empty. Well, I want to thank all of you for joining us. But before we end, I think we got a little bit more of that. What's the song? Just
Out in the country.
Out in the country.
Before the breathing air is gone, before the sun is just a bright spot in the nighttime, out where the rivers like to run, I stand alone and take back something worth remembering.
Jeanie, Gregg, Karl, Adie, thank you for joining us on this podcast.
Thank you for allowing us to be a part of it.
Thank you for sharing time.
And thank you to all of our listeners for your continued support. We'd also like to do a special shout out to all of those supporters who've donated more than $250, including
Brian Castle, Victoria Brond, Susan and John McFadden, Christopher Heck, Emise Samoji, Matt Schuster, Carrie Hagan, Lloyd Woolstat, Kari Levy, Marnie Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Young, Cindy Harris in honor of Emily Guillot, April Sear, Anna Naik, Xinyi Wang, Sudha Chandrasekhar, Michael Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rack, Meg Walhagen, Xinyi Wang, Sharon Bragman, James Tulsky, and Yana Scharf, Kelly Strait, Michael Bordowski, Jessica McFarlane, Gretchen Schwarzy and Joshua Mesrich, Rob Razak, Diane Meyer and Sean Morrison, Elizabeth Chung, John A. Hartford Foundation, and Harry Hahn.
thank you very much for your continued support over the last year. Your support keeps these lights on.